Okay, so the books that we're using, a couple of them, I know there's three on there, I believe. But so obviously the DSM is one of them that we use, and we'll get that glare off of there. So the DSM is the Diagnostic and Statistical Manual of Mental Disorders. And we're in the DSM-5 now. Then there's the text revision is the one I recommend. There's one, it's a purple one. That's the original. There's not many changes between the five and the TR. There is just a little bit of revisions, and it would tell you what those are up front. So obviously it's a huge book, right? So it's got a lot of stuff in it, but and we'll go through quite a few of them that are in here. But it's in categories too. So, and we'll go through all of that stuff too. But highly recommend if you don't have that to get it. We'll be going through a lot of those things today. The other one is this one called Diagnosis Made Easier. And it's got a lot of like how, taking it through in kind of in layman's terms of stuff in the DSM, but also has, kind of like case studies, and it goes through each one of the diagnoses and all that stuff too. Tells you about the symptoms and signs, just really puts it into easier terms. Um, Especially if you're doing notes and things like that too, and you are working to diagnose somebody in some way. This will help you kind of put things into easier terms, if you were. So diagnosis made easier, right? So that's another good book. Let me get into our syllabus here. I like Zoom, but sometimes there's so many things you got to do to get what you're wanting to look to up. So, okay. Okay, let me know when you can see it. Good? Okay. So, diagnosis and treatment of abnormal psychology. So that would mean that there's normal psychology, right? If there's abnormal, then there would be normal. So I don't really know if I really like the word abnormal. You know, but anyway, so we'll just go with like, the treatment of psychological disorders or whatever. Okay, so the course is designed to study the symptoms and the underlying personal and interpersonal dynamics of the major categories of dysfunction as found in the DSM manual that we just kind of took a look at. Special attention is given to providing an understanding of these disorders according to a Christian worldview. Okay. Um, so the general objectives, you guys can read through that. So understanding psychopathology, what creates, something that needs to be diagnosed, what creates um, abnormal psychology, if you will. The student will develop a deeper understanding of the origins, kind of where this came from, um, and a better understanding of each of the diagnosis that we'll be talking about. We'll be exposed to different modalities and treatment options, how to handle, some of these things that we'll be talking about. Student will be able to dialogue with other professionals and third-party payers. So we will tomorrow. I do this training with our counselors every Friday. And so tomorrow, the ones that want to jump on, because I'm telling them about the class that that we're in right now. And so you'll be able to ask questions of some of the counselors and everything. What have they seen? How do they handle a diagnosis and so on. Okay, then specific competencies, the student will develop a deeper understanding how to practice self-care for personal wellness and the student will become proficient with diagnostic system of the DSM-5 that we just kind of took a look at. Okay, so let's get into the requirements. So class participation, of course, then the readings, and then here's the written assignments that we'll be going through. So it'd be right, you guys are familiar with the APA seventh revision of the APA style of how to format and write and all of that. So the first one is a case study that will be provided in class, right? So I'll get that to you. A student must write a 4-page paper that determines the key issues presented, providing diagnostic impressions based upon the DSM-5. So, um, and so this includes treatment recommendations that support a collaborative effort and include a biopsychosocial spiritual approach. And we'll go through that today, what that looks like. The case study must include at least 4 resources, journals, things like that, could be books. Um, and one of them could be the DSM, right? So if you're getting information out of that. And so 4 resources in addition to referencing the course textbooks in the Bible. So I would say, I know it says in addition to, but you can count one of the 4 as the DSM because obviously we want to work out of that one. So count it. Okay. Then the next is write a 10-page research paper according to the guidelines below. Select a diagnostic a diagnosis from the DSM. And if it's in the DSM, go for it. I know it says ask for approval before you start working on your paper. If it's in DSM, like PTSD or something that you guys, I know a couple of you people talked about, a couple of you guys talked about trauma and things like that too. So if you want to work towards something that's trauma focused, you can do that. Use at least 6 scholarly resources, preferably peer-reviewed sources like books and journals. So obviously we're not going to go Google things and use from the Google like people's blogs or something like that. So this has got to be something that's, like from Google Scholar or um, from any, the online libraries that you use, things like that too. And then journals. So 6 of those. And also in that, when I say it says besides the textbooks, you can include the DSM. So whenever we do these, you can include DSM as one of the resources. Okay, and then so include the following areas: a succinct overview of the chosen disorder in the DSM-5. Um, yeah, do not copy and paste from the DSM-5, kind of put it in your terms and things like that. And so you'll understand it better once we kind of go through some of these. So this information must be evaluated and reworded into your own words. Okay. Potential causes of the disorder. Is it maybe genetics, hereditary, social, cultural environment? Could be substance use issues, things like that that have brought it on, things like that. So, or some sort of behavior. Discuss how this disorder is viewed through a Christian worldview. Okay. Possible treatment interventions to help someone who is struggling with this disorder. So you can kind of look at, so say it's anxiety. Okay. So general anxiety disorder. And you can discuss what that looks like, how it's viewed from scripture. The scripture would say, be fearful for nothing, and so on, right? Um, be careful for nothing, and just where would it show anxiety in the Bible, and what's the Bible say about that? Okay. Possible treatment interventions to help someone struggling. So obviously, like with anxiety, you can do mindfulness and things like that too. So what would be some interventions that you could use that would help somebody with anxiety? So that's just an example. So whatever you choose, you will come up with those on your own. So number three says combination of reflection and interview. Uh, there's two parts to that. And so, part one, the student will conduct an interview with a Christian LPC, somebody who's licensed, and write a summary of that interview. Okay, so the student will ask the following questions of those individuals. And so, what we could do is I can probably schedule like one person and you all be on it at the same time, and we can ask these questions, to save time for everybody. We could possibly do that, or you can choose somebody of your own. So, okay. So okay, let me see. Okay, the student will ask the following questions. How does a Christian worldview affect your treatment of mental illness? In your opinion, how are sin and psychopathology related? Have you found any diagnosis in the DSM-5 challenging to interact with? And if so, explain. And then how have you seen the church interact with issues of mental health, both in a positive and unhelpful ways? Okay. So the summary will include a short biography of the professional, a history of their specific professional context, probably place of employment. How did they get there? Where did they go to school? How did they get there? Um, what type of people do they see? Do they see couples? Do they see individuals? Do they see children? Do they see people with just strongly see people with mental health issues, or do they not? Do they stay away from those types of things? Right? Where somebody is diagnosable, do they stay away from that type of counseling? And I don't mean stay away from. What I mean is, do they just typically adhere to one type of, counseling? Some people find, something that they're really good at and they stick with that. Maybe it's a couple work or something like that, just strictly couples or something. Jennifer, you had a question?
Yes. So, does it need to be a licensed person? Or can it be like somebody who's a psychologist?
Well, a psychologist should be licensed too.
Would they be licensed if, like, she's the
Yeah.
head psychologist of a children's unit at a hospital? So, or
Yeah,
like she works with adolescents. So,
if they've got some letters after their name, go for
okay,
it.
okay, thanks.
Yeah. Yeah, absolutely. Yeah, good question. Okay. So part two is write about your reflection on answering the following questions. In what ways have you been personally impacted? So this is going to be about you. So first it was about them, now it's about you. How have you been personally impacted by one or more diagnosis of the DSM? So maybe you have somebody in your family that was diagnosed with something or so on. Um, in what ways has your family been impacted by one or more of the diagnosis? So you personally, and then how has your family been impacted? How is mental illness a family problem? Um, so this can be something like maybe you take the you can take a social aspect. Maybe it's their environment that they grew up in that would make that something, or it could be hereditary, genetics, things like that. So, kind of you can kind of go one of those routes. How have you experienced the church being either helpful or unhelpful when you have struggled? So put in here, do not overthink defining the church, right? It could be anybody that is Christian, right? How have you found something to be helpful or unhelpful? Because you can have people go, okay, let's go look and see what the scripture says. Absolutely. And there's a lot of good wisdom in there too. But there can also be condemnation. It's like, well, you must be sinning. Just take the book of Job, right? What did you do to make God mad? All that stuff, right? So, how have they been helpful and unhelpful in both of those ways? Okay. You could even look at it as like going, maybe you've spoken with a pastor before, and a pastor just doesn't have the cycles to see somebody who needs a lot of counseling. So that could be very unhelpful too, right? And so hopefully they have recommendations of what to do. But if we're wanting it strictly from that pastor and they don't have the cycles to that, that's unhelpful, right? So you could even say, maybe it's about availability or something. So do any of the treatment options discussed in this class help you maintain personal wellness? Okay. So maybe you've taken something from what you've learned so far in this program, and it's helped you to maintain a personal wellness like self-care or something. So how have you really focused on self-care for yourself, and how is that working for you? Okay, and then there will be a final for this class, and we'll make that available. So it's a comprehensive examination of all the material covered in this class. Okay, it's not tough. It's really just how do you use the DSM, and you'll learn how to diagnose through the DSM. So it's really a little bit of that where you've got some case conceptualization, and you'll be diagnosing somebody in I think there's three or four of them in there. So it's actually fun. I don't know if it's fun, but yeah, it's something that's really good to take a look at. Okay, so the test will include short answers and a case conceptualization section. So this exam will be broken up into those two sections, and the final test will be a vignette-based and open book. So you'll be able to use your DSM and so on. So this is not a copy paste or anything like that. So you'll be, using your own words, but please be thorough with your answers and explanations to each of the questions. And it says points will be counted off for answers not containing thorough explanations for how you came to the diagnosis. Okay. And so we'll make that available to you as well. Is there any questions about those? I know sometimes it's like you have to get into them first, and then you'll have questions, and that's fine too. But any questions up front?
So you already have the final diagnosis, the final exam document available.
Is it?
Yeah, I already
Okay.
opened it. I'm assuming
Oh,
that's
okay.
okay because it was available to open.
Yeah, just do it
Um,
any. Yeah, you can do it in any time.
okay, I wasn't sure about that. But then the other part of that was, I'm assuming we probably can't do our research paper on autism because the final exam vignette is on autism.
That's okay.
Is that okay?
Yeah,
Okay.
absolutely.
Okay. Cool.
Yeah, whatever is something you really want, have a heart for and want to learn more about.
Okay.
Yeah, absolutely, go for it. Yeah,
Okay.
and I think I remember making it available yesterday, just so you guys can do it, when you want, and so
Yeah.
you don't feel the pressure of
No,
doing
I
it
I
kind of
appreciate
thing.
that too, because when I saw final exam, I was like, oh shoot, we haven't taken a test this whole time. And
Yeah,
then I looked at it, and I was like, oh, it's just more writing.
yeah, yeah,
So we're good. Awesome. Thank you.
yes, absolutely, yeah, yeah. I know because summertime classes are just kind of jam-packed and shorter and all that good stuff too. So yeah, I want to help you guys out, and it helps me too because I got to grade all these things. So it's for all of our benefits for sure. Okay, let me see if there's anything else in here. APA, just remember APA format, seventh edition. And you guys have been using that for a long time too. So, okay. Yeah, if you have any other questions, let me know. And okay, so I will get to, we will get into some learning here now. Hmm. Okay, so now we get into the diagnosis, and we'll get into some things in the DSM here shortly. But we kind of want to go through just an introduction of what this is all about. Okay. Okay. So we talk about the DSM. So we went, through the syllabus. We'll be getting into the DSM. So there'll be some forms that we'll be using, like the psychosocial diagnosing, the intake and all of that stuff too, to become more familiar with it. And I know I use it in a couple of other classes. And so just make sure that you're taking good notes. So why do we want to diagnose individuals? Okay. So it's really if we have something and we find something in the DSM that kind of gives us a way to treat individuals, it makes it that much easier on us, right? So if we're going to write a treatment plan up for somebody with generalized anxiety disorder, we'll go into the DSM and it'll say, okay, this is the criteria for us to be able to diagnose that. And once we are able to do that, then we can put a treatment plan together. Okay. So what works best, for treating somebody with anxiety, right? So there's a lot of literature out there. I'm teaching another class on research too, and we're going through a literature review right now. And in that literature review, we're having them go out and find a bunch, pick something that is a diagnosis of something, right? So if it's OCD, anxiety, or whatever, and then and is it in children, adults, or whatever? So then go out, find the literature that um, other people have done research on that helps them to treat, the diagnosis that this person has, right? So there's many people that have gone out before us that have written a lot of good material on how to treat whatever you're looking for, if it's anxiety or so on, right? So, what's the prognosis for this diagnosis, right? Protection of services. How do we be more empathetic, with somebody with, if it's anxiety or whatever? How do we be more empathetic with them and let them know, hey, I had one individual that had really severe anxiety, and I'm like, was, doing counseling with them, and one of the first things I said was, hey, I have anxiety myself in issues, and this is what I've done to kind of overcome. And you could see how everything had changed with this person, right? So you gave them hope, right? And things like that too. So using empathy, treatment alliance and compliance, research. So if we understand more about, say it's trauma and maybe they have PTSD, and we go out and do more and more research on it, and then we learn more and more, we can help that person, but we can help more and more people too. Um, but we can't really do all of this unless we give these individuals a diagnosis and have a starting point for something. And then, it talks about here, it says reimbursement. So really, if you're working with insurance companies, they want a diagnosis, right, to be able to pay you, right? As a psychologist, as a counselor, or whatever, they want a diagnosis so that they know, okay, here's what the treatment plan should look like and how long it will take to work with these individuals, right? Because they're only going to pay so much for so many sessions and so on. Okay. So what's the difference between assessment and diagnosis? So the assessment is the process that the clinician uses to probe for history. So when somebody comes in and we're going to ask them all of these questions in our intake to find out the best information that we can. We're going to take really good notes. And so when we see symptoms and signs of things, then we're going to probe a little bit more into we're formulating a hypothesis that they have this type of issue going on. So then we're going to keep asking better questions to probe and to find out, are we correct or are we chasing something that's not there, right? And we need to go another direction. So it's all about asking um, good questions, better questions, right? So we want to understand their symptoms and their current functioning to kind of determine the direction of the treatment, okay? Diagnosis is the assignment of a formal label that encompasses the clinical findings. So here's, when I'm working with counselors, I say I don't like diagnosing individuals or putting a formal diagnosis on their treatment plan, other than something about like adjustment disorder of some sort. Because um, first of all, I think, when somebody is being diagnosed, it better be through, a really good assessment and somebody who's used that assessment and has been trained in using it so that they can have a formal diagnosis. And I just wouldn't want anybody who's going along and saying, well, I think you have schizophrenia, you know, and you're diagnosing them with something and it's not true, right? And so I just think we have to be really, really careful with the labeling individuals, right? Because they can take that label and then they become that. Okay, so we just want to be careful. So there's steps taken in the assessment process to rule out similar diagnosis where you can have dual diagnosis, you can have comorbid situations where you have one and then you have something else that they are that you could diagnose them with as well, and we'll get into some of those. Okay, yeah, we'll get that. Purpose of assessment and diagnosis provides a common language that is acceptable across multidisciplinary settings. So if you were talking, if you're working as a mechanic or you're working as whatever field you're in, they have their own languages, right? That people understand. So when you're a counselor, psychologist, psychiatrist, and all that, there's certain languages that you're going to use that people understand, right? So it's learning those languages. So diagnosis has those things. So as we get into some, you may learn new languages, right? That people use. Um, so it organizes clinical findings. You may at times help predict the following, like the likely course, both past and future selection of treatment protocol, and then outcome of a specific disorder and being able to put a treatment with it. Okay. So we don't really need to do this here, but just think about it for a second. What is your current perspective on psychopathology? So, how individuals get to where they're at in mental illness. So, our perspective is formed out of our theory of persons, But it's, just kind of thinking when you have somebody sitting in front of you and you are thinking of a diagnosis with them, it's like, how did they get to this spot? Right? And if you learn from one, you can learn from many as well. How do many people get to this spot? And that's where the research comes in handy. So when people do this research, they've already done it for you, and you can go out, read more about it, and it helps, with their treatment. Okay. Understand what it means to be human, what being different is like. And what I was looking here is the illness wellness continuum. Um, what you're looking at is we're always trying to move people to the right here, right? Into wellness. And when a person has some form of disability, there's symptoms and signs. And then, once we understand these symptoms and signs, we can look through the DSM for what, what type of issue is going on with them at that time. Then we have awareness, and we can educate ourselves as well as the client sitting in front of us, right? And so that's where the education comes in. And then when there's treatment, then there's growth. If they're following the treatment plan, if you're following the treatment plan, then they can grow in that and overcome. Or if it's something that it's not something that they will overcome physically or anything like that, uh, how do we, I don't want to say live with it, but be able to make it part of us so that we can have where it says high level of wellness, right? So how do we kind of live with that? Okay. Okay. I like this part here where it says a patient's history often provides better guidance for diagnosis than does the cross-sectional appearance. So that's why I like these biopsychosocial things of doing a history report with them and asking all of these questions that will help you. So, and it could be, what was your environment like growing up? If you're looking at attachment issues in individuals, okay, what was that environment growing up? How did individuals within your family handle conflict? Okay, what was that environment like? How long have presenting concerns been present with you? How long have you been living with this? Has it been all of your life, or has it been something recent? And then we can ask questions. If it's something recent, we can ask questions along the lines of figuring out something maybe that's in their environment, or maybe there's been substance use or something like that too. So maybe that's going on that has caused something new in their mental health. Just like here, so do drugs or alcohol appear to cause the onset? Do they regress with medication, or are they more sporadic, and so on? Okay. Older history can be convenient, but it doesn't mean it's always accurate. Um, because if somebody comes to you and they say, "Oh, I was previously diagnosed with something," and you're going, "Okay, then we can work with that." But what if it wasn't a good diagnosis? Or what if they, don't have something anymore and it's something new, and this diagnosis doesn't fit what they're doing? Joyce, you had a question? Oh, you're on mute.
I did.
Yeah.
I was wondering if you found, as a counselor, if there was any rift between a psychologist and a counselor and being able to diagnose someone. I had an experience with my grandson that I took to get some counseling, and what I heard was take to a psychologist, not a counselor, because a psychologist is better than a counselor. So I'm wondering if, there's a lot of conflict or undermining credentials and all that, if you see that.
Yeah, I would say there can be, and that's why I say, as counselors, if you don't have the training, like a psychologist, like if they psychologists generally will go, okay, I'm in this field, this part of the field, and they'll go and get certified on assessments and stuff like that, trained on it, certified on it, so that they can be the professional in it. Whereas, to me, I'm not saying a counselor can't diagnose because you can, but I would just say, is that person specifically trained with an assessment? Does that make sense? Yeah.
So
th-
we need to, as counselors, we need to tread lightly.
yeah. Oh, definitely,
Yeah.
definitely. Yeah. And it's funny because I'll be doing supervision with individuals, and then they'll have some kind of diagnosis up there. And I'm like, how did you arrive at this? Well, is this is what it appears? Well, okay, what about assessments? And did you do this assessment? Did you do this assessment? All of these things that would do. No, I didn't do those things. Well, I don't know that we can diagnose somebody without, having, just seeing signs and symptoms of something is probably only 10% of what, maybe 20 of what it could be. If we don't have those assessments there, you know, how do we back it up?
So is there ever a time where you do not diagnose someone as a counselor?
I don't at all.
You don't at all?
No, I may write
Okay.
it down saying, this is what I think it is,
Hmm.
and maybe go with my treatment. But if I
Hmm.
think it's something severe in any way, I will have them go work with
Okay.
a psychologist or something just
Yeah,
to
that's
double
that's what
check
the
me.
vocational counselor told me as well, that he refers them.
Yes.
He doesn't diagnose. He doesn't even, he not outside vocational area, he doesn't treat anything. So,
Yeah,
yeah.
exactly. Yeah,
Okay.
yeah. No, I think if you can have signs and symptoms of people and you can say, well, I'm going to base my treatment plan on what I'm seeing here. But if it's like I say, something severe or something that needs to be really um, taking a look at, it's like, okay, going to a general practitioner, and you go, hey, doctor, I've got this lump, right here. So, I mean, even I went in and there was this lump on my back or whatever. And so the doctor goes, oh, it's probably lipoma, which is they call it fatty tumors or whatever, right? Yeah, we can, but you need to go check it out just to make sure, and blah, 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 So you go and do that, and then it comes back, oh yeah, they took part of it and there's no cancerous to it, and then they can just remove whatever, right? So, but a general practitioner is what a counselor is too, is the way I would kind of equate it. You know a lot about a lot of things and everything, but there are specialists out there that I refer to. So just to make sure that I'm on point and that if they want a formal diagnosis of something, I'm not going to give it to them. I'm going to have a psychologist do that. Yeah. Great question. Thanks for that. Okay. Okay. So collateral history sometimes beats the patient's own. Okay. First, listen to your clients, obviously. Recognize some clients may lack perspective on their own difficulties. Um, Utilize extreme caution when countering clients' perceptions, because of a lot of times, so you guys may have done this before where you go into a you go into a doctor and you go, well, I went out on WebMD and this is what I think I have, right? And they go, don't do that. Right? Don't go out on WebMD because every time you go out on WebMD, what's the end cause that you have? Cancer every time. It always goes down. You got cancer, right? So here's a funny story about myself. Right? So I have this pain that was in my front here and then in my back right here. So it radiated from front to back. So I go out to WebMD and it says I have pancreatic cancer, right? Well, my father had just died recently, before that of that. Okay. So I'm like scared to death here. Okay. Maybe it's genetics or something, like scared to death. So I go in, they go, oh, there's nothing wrong with you. Go to my chiropractor. He goes, oh, you got a rib out of place. Crack. and the pain goes away, right? So see, you can't always go by, if you have a pain or whatever, right? So that's what people do is they'll go out and say, okay, I've got these signs, symptoms, and then okay, oh, wow, I must have this mental disorder or something like that. Okay. So obtain collateral history whenever possible. Yes, and this is always good to be able to ask this until you come across somebody who is adopted or something like that. So it's not, they won't always have all of the history that you would want or that they would need. Okay, so that's going to happen. Okay. Signs beat symptoms. So signs are what you observed about the client. So it's objective. So signs are what you observe. Symptoms are what the client tells you that they have. Okay. What seems to be wrong inside them. So that's more of subjective on their part, right? So signs are what you observe and symptoms are what they observe. Okay. Um, Crisis can affect perceptions of self, worldview, relationships. These can tend to sway the pendulum towards either extremes. So if you have somebody that comes in and they're talking, they're having something going on in their life, anxiety can be high, and it could, really um, like we're here, sway the pendulum towards more anxiety in some way. Okay. Understanding this context allows the counselor to empathize while maintaining a clear picture of the client's experience. We want to understand what their experience is, but we want to be objective about it and say, um, here's what we're seeing as well. Okay. Objective findings beat subjective findings, so here's the other part is that's where literature is going to come in research. So doing the research on people, on what people have done before you is always so valuable, right? Because like I said, they could come in with some kind of symptoms and thinking of what they think it is, and it's not correct at all. Okay. So my another thing is consider the family history, and that's what your doctor does, right? So don't they always ask you, so is there any history of this in your family? Right. So we want to, as counselors, ask these things too, because there's going to be a lot of information that you can gain from where they've been, where their family's been. So there are strong genetic components attached to many disorders like depression, bipolar, psychosis, and so on. So you could probably all think about your family history and something that you have that's been generated out of genetics and things like that. So mental health is the same. So do y'all know what Occam's razor is? Okay, it's like, what is the simplest answer, right? If something has two possible explanations, you should choose the simpler one first. And I don't know if I have this. Yeah, right here. Okay, so we call this zebras and horses, right? So aren't you going to see more horses than zebras if you're in Missouri or wherever you're, Texas, all that? You're probably going to see more horses than zebras unless you're at a zoo. Okay. So what this is really kind of telling you, so you're more likely to be met with common disorders than you are with uncommon ones. So, and what this is kind of saying is, oh, here's the other part. I want to throw this in here. Be aware of the population that you're working with. Okay, so if it's just ordinary population and they come in and they're showing signs of mm, uh, X, so maybe it's, some form of depression or whatever, and Um, and so you want to go, or if it's anxiety or something like that, you want to go and rule out the most common disorders first, right? Until you're ruling those out, and then maybe you start going towards the more uncommon ones, okay? So that's all that's saying. So always consider common diagnosis, but not to the point of ignoring other possibilities. So you can say, here's what I believe it is, but here's where it could also, this is what it could also be. And we'll talk a little bit more about that later, when you are formally kind of diagnosing someone. But you want to um, kind of go with the common one first. Okay, so we won't talk about this much, but so the DSM, um, it really came about. It switched over from DSM-4 to DSM-5. I think it was around 2014-ish, around that area. So it's been around for 10, 12 years now, for quite a while. And I don't know how long, it is between each DSM. Seems like it's about 20 years or something. But there's always some diagnosis that's on the cusp of being put in the DSM and that's not, So I'm sure as this world keeps changing, the next DSM 6 will have all kinds of different things that maybe even some things that we're not even thinking about at this point. But then there's going to be other ones in there that are a mainstay, which they will always be in there, like generalized anxiety disorder and so on. Okay, one thing I do want to show you. Um, so Well, before I get to that, so the primary goals for the manual's new frame is to serve as a practical and functional, flexible guide for organizing information so that you can readily look for it. So they kind of lump things together, right? So all the anxieties together, all the depressions together, and so on. So it helps researchers better study how disorders relate to one another, especially the way they have it designed. And it leads obviously to better treatment for your clients. Okay. Sorry, skipping through some of these. This is more really in depth about the DSM that you don't really need to know. You just need to know that the DSM is um, what it's used for. Okay, so there's 3 sections to the DSM. So section 1 is the basics, right? So introduction. Do you guys all have your DSM with you? If you do, you can kind of open it up and see, kind of section 1, kind of what it's saying and the classifications for it. So it's the introduction, the DSM-5, how it is used, and so it says a cautionary statement for the forensic use of the DSM, so how to use it the best throughout the introduction here. And I think it goes all the way. There's the introduction, use of the manual. If you have the TR, it's on page 21. How is that used? Here's a cautionary statement. It's on page 29. And then it gets into the section use. So section 2 here starts on page like 30, 31 or so. Anyway, so it tells how to use this. So this section, it says containing the diagnostic criteria approved for routine clinical use with the ICD-10 diagnostic codes. For each mental disorder, the diagnostic criteria are followed by the descriptive text to assist in the diagnostic decision making. Where needed, notes to facilitate the selection of the appropriate ICD-10 code as well as recording procedures are also provided. So then you'll get into, starting on page 25, neurodevelopment disorders. And then it goes into intellectual development disorders and oh, another one that we were just getting ready to say about is it's called differential diagnosis. So that's the one where it's saying it is this, I believe it's this, but it could be this too, as a differential. So So as you're looking through, it's like, okay, be aware. Like if it says general anxiety disorder, here's the other possibilities that it could be and the specifiers and so on. So we'll get into some of that. But just to let you know, then comorbidity is the next term that you would need to know. And what that is like, okay, you have this and you have this. So it's a co-occurring disorder. Okay. So that's section two. Section three, emerging measures and models. So it's got, some assessments, things like that that you can use. Let's see. And that's way in the back. On page 903, it's got conditions for further study um, that you can read about where, kind of where they're heading. Alphabetical listings on page 929. And it gives the codes for each. Okay, and then obviously in the back you got um, the index and so on where you can look up things and gives you the page number. But yeah, this is a monster book. There's a lot to it, and you could spend a lot of people spend their whole lives just in the DSM because they use it a lot and getting to know it. And it seems like every time I open it up, there's something new that you learn from it. So okay. So the DSM, go ahead, Maria.
I was trying to order mine and
Yeah.
it says that it's unavailable. When I click the link, it just says sorry, not available. Then when I click it on Amazon, it says that it's it's not available. I was just wondering where else could I get it from that's
Hmm.
reliable.
Wherever you, oh, I've got mine many, many years ago. Wherever you all, I think I ordered mine from Amazon. Yeah. Go ahead, Maddie.
I think it's called used books. Hold on, let me look it up. I think it's called the used books website. Um, M5TR. I'm just looking to see if it's on there right now. Thrift book. That's what it's called.
The what?
Thrift books.
Oh, okay.
And I typically get pretty good quality uh books from there. I got a new DSM-5 technically. Oh, looks like they don't have it. DSM-5TR. Oh, I typed it wrong. Oh no, they have it. Yeah. Oh my goodness. Shoot, I should have done this.
How
You can
much
get it
is it?
for you can get one for $80.
Oh,
Depends
that's
on the
good.
quality. The most expensive one on here is 145. But that looks
Yeah.
like it was gently used.
Yeah.
There's like gently used, moderately used, and then like highly used. And the more
Yeah.
used it is, the more expensive it is. But yeah, no, there are
So,
some on here.
yeah. So I'm out on Amazon and I see some DSM-5 TRs out there and you can get them used. Like here's one used good condition for 99 and then new $148 um up to 120 or 220. Yeah.
I have, I have a question about that because I got mine used on Amazon for like
Uh-huh.
90 plus tax. But then I was reading on the book that you're supposed to have the little label or the little QR code that's attached to the book to be able to scan it. Well, I looked under my label and my QR code's missing, so then I ordered another one. So I wasn't sure what to do with that.
I
My
don't
book
know.
looks normal, but they just said knockoffs are a big deal. So
Anyways,
how do you, I'm not sure how to know
well,
whether
my oh, Authentic. See on the back of it, on the
Yeah,
back of
it
the book,
talks, yeah, on the back of the book. Let me see. I think
authenticate.
it's,
Yeah.
yeah, authenticate your copy. There should be little metadata stickers that's really attached to the book, and it says you get extra stuff with it. I wasn't sure how important that is and
Hmm.
how, you know,
I don't know. I think you could probably search for it and get it. You know what I mean? Actually, you know what? You can get the whole DSM online on PDF.
okay.
Really, you're not even buying it.
That's the one I
Okay.
have too.
Say what?
I have the PDF form,
Okay, there you
but
go.
it was I was trying to follow with you whenever you were
Oh,
talking about it. But I feel like I know I also wanted hard copy too, because
yes, yeah.
if anything were to ever happen. Now, do you have the blue or do you have the purple one?
Blue, yeah. That's the TR. The purple one's is the original. Whatever. It's not the revision, I guess I would say. Does that help? Yeah. Mm. Yeah, it's a monster. I
I
think I
just
paid 180 for mine or something.
I just scanned the QR code, Jennifer, and I don't know what special resources it said you were supposed to get, and it's not anything that's worth an extra hundred and something dollars.
Okay.
Yeah.
So we won't be actually diagnosing people with it. We're using this as a resource. So
Yeah.
it's not like we will, like they'll say, oh, we don't like your diagnosis. Let's see the manual of the DSM that you're using and
No, no.
take you to psychology jail.
Yeah, psychology jail. Yeah, no.
So,
No,
okay.
it's really just there for your information. And now
Okay.
you can get into a job where, you see a certain demographic of people and you need to understand it and you will be diagnosed. I don't know how all of that works, how I know that, like if you're doing insurance and so on, and you as a counselor can diagnose, right? But
Okay.
they may not take it. It's kind of, up to them. Say you're in court, is the court, the lawyer's going to take, you know, I look at, when somebody's doing their internship and I say, you go to court and the lawyer goes, okay, what's your qualifications? And they go, well, I'm a student at Calvary University and this is what I think, right? So you could be totally right as rain, but really are they going to go to a psychologist that's been in the business for 20 years and has done the assessments and has the letters after their name or something? They'll probably take that over it. See what I'm saying?
Mhm.
So it's not saying that you're wrong by any means or anything like that, but I want somebody, if I'm going to give something so formal to these individuals, I want to check and double check and make sure that I'm doing everything correct for this individual. Yeah, great questions. Okay, so understanding the disorder sections, right? So each disorder section starts with the criteria of being able to um, diagnose, okay? And then there are some diagnoses that have specifiers and severity, okay? And we'll get into some of those. So this is followed by a narrative explanation of the disorder's features. So let's look at one. Okay, let's look at, let me find one we can look at real quick. Something that we all, okay, so here's generalized anxiety disorder. If you have the book, it's on page 250. If you have, the other, just kind of look for general anxiety disorder in it. So as you're looking in it, it's got the criteria first, right? So the diagnostic criteria for generalized anxiety disorder: excessive anxiety and worry occurring more days than not for at least 6 months, about a number of events or activities such as work, school, and so on. Okay. So the individual finds it difficult. This is letter B. The individual finds it difficult to control this worry. So they're always in worry mode, okay, for 6 months. Then you go to C under the criteria, and it says the anxiety and worry are associated with three or more of the following six symptoms. So they have to have at least half of the symptoms. So with at least some symptoms having been present for more days than not for the past 6 months. So it's really prevalent in their life, okay? So the note underneath C would say only one item is required in children for them to have it. Okay, so to diagnose it with uh, adults, it's three, and then with children, it's one of the following. Okay, so the following six symptoms are restlessness or feeling keyed up or on edge. Two, being easily fatigued. So three, difficulty concentrating or mind going blank. Four, irritability. Five, muscle tension. Six, sleep disturbance. So that could be difficulty falling asleep, staying asleep, restless, and satisfying sleep, and so on. So if somebody comes into you and said, I believe I have anxiety. Okay. And you're going to go, okay, so tell me about that. Are you restless? Are you easily fatigued? Do you have difficulty concentrating and your mind goes blank? Is there irritability? So at least three of the six that they must have for 6 months and more days than not. Okay. So D, under the criteria, it says the anxiety, worry, or physical symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. So that's another form of criteria that you have. E is the disturbance is not attributable to the physiological effects of a substance. So, for example, a drug of abuse or a medication or another medical condition like hyperthyroidism. So F would say the disturbance is not better explained by another mental disorder. So it means you've ruled out all the other things and you've come with they have general anxiety disorder based upon three of the six criteria at least, and the rest of the criteria. Okay. So then under that on page 251, it has the diagnostic features. So we won't read through all of that, but it says the essential features of generalized anxiety disorder is excessive anxiety and worry about a number of events. The intensity, duration, or frequency of the anxiety and worry is out of proportion to the actual likelihood or impact of the anticipated event. So say um, you are in constant worry about finances and things like that too. So the individual finds it difficult to control the worry and to keep worrisome thoughts from interfering with attention to the task at hand, or they go blank, or one of these other six, they're irritable all the time, probably because they're not sleeping and they're constantly worrying about something. Okay. And so you can, read more about that. It says several features distinguish generalized anxiety from non-pathological anxiety. First, the worries associated with generalized anxiety disorder are excessive and typically interfere significantly with a psychosocial functioning, whereas the worries of everyday life are not excessive and are perceived as more manageable and may be put off when other matters arise. So if they have generalized anxiety disorder and they're not able to put it off, or if other things arise, they're still in worry. Okay. So a lot goes along with that. So just to be able to diagnose it with it, have to read through all those things. Then there could be associated features with it. So the physical part of it, they could have a lot of muscle tension, There may be trembling. So you've seen, people who are sitting there and they have high anxiety and their hands are shaking or something. Well, so then we're going to look at that. Is that anxiety or are they heavy drinkers and they have DTs or, what's going on in their life? So you're going to be able to ask these questions. Many individuals with generalized anxiety disorder also experience somatic symptoms, sweating, nausea, diarrhea, and exaggerated startle response. So symptoms of autonomic hyperarousal, like accelerated heartbeat, shortness of breath, dizziness, are less prominent in generalized anxiety disorder than in other anxiety disorders, such as panic disorder. So if they do have this, if they have the heart, erratic heartbeat, like 140 beats per minute, when the normal would be 70 something, right? Do they have shortness of breath? Are they being dizzy? So maybe it's not generalized anxiety. Maybe it's panic disorder. If they go into panic a lot. So, then you go and look over in panic disorder. What does that do? So then you could try to distinguish between the two. So here's another really important aspect. It's called prevalence, right? So prevalence is let's read this part. The 12-month prevalence of generalized anxiety disorder is 0.9% among adolescents and 2.9% among adults in the general community of the United States. The mean 12-month prevalence for disorder around the world is 1.3% with a range of, and so on. The lifetime morbid risk in the United States is 9%. Women and adolescent girls are at least twice as likely as men and adolescent boys to experience generalized anxiety disorder. So when you're looking at prevalence, um, here's like a kind of a story that I had with a student that from another university, but they were a counselor at Abundant Life. So they had this person worked with like 10 couples. And within those 10 couples, seven of the 10 males that she worked with, she said, this guy um, he's a narcissist. He has narcissistic disorder. And I'm like going, okay, statistically, if you have 70% of your men that you say have that, there's no way, right? Because the prevalence of narcissism is low, okay? Or would be lower than, her having that many. Now, but you could look at the demographics. Now, are they all coming from a narcissistic group counseling or something? And then she's getting all of those, So yeah, maybe then, but so come to figure out, I would ask a lot of questions. Come to figure out, she was divorced and she had a husband that was a narcissist. And so she would see traits in other people, and then she would just, create that label for them, right? So that's, one thing, you have to be careful about is the prevalence of what you're kind of going. And that kind of goes back to horses and zebras, right? So you're going to diagnose with horses before you would zebras. Okay, does that make sense? Okay, so then the development and course. So that section says this is how it could possibly develop over your lifetime, how the disorder comes. Risk and prognostic factors, temperamental, behavioral inhibition, negative affect, harming, avoidance, reward dependence, um, and so on, genetic, physiological, and so on. Okay. So we go to cultural related diagnostic issues, then sex and gender related diagnostic issues associated with suicidal thoughts and behaviors, and so on. So, anyway, you can read through those, but then you get down to the differential diagnosis. And so, what this is saying is you've looked for all of these things, and these people are meeting the criteria of something. Let's rule out everything to get to what it could be, okay? So a differential diagnosis could be, so if you diagnose them with GAD, you could also put in here, and it also could be this, right? So the first one is anxiety disorder due to another medical condition. So maybe the medical condition that they had caused it, and as soon as that medical condition goes away, or it's controlled in some way, maybe the anxiety goes away. Okay. So is it something maybe caused by a medical condition or substance use or a medication? And that's on the next page, 254. Or is it a social anxiety disorder? Then you're going to ask questions. Okay, when does this all come about? When you have anxiety, when do you have it? Oh, I have it at parties, or I have it speaking in front of a lot of people, or whatever. Okay, so maybe it's the social aspect. Separation anxiety could be another one. Panic disorder. So these, look at all those ones that we're ruling out by asking good questions, right? Illness anxiety disorder and somatic symptom disorder. Could it be OCD, obsessive compulsive disorder? So we want to rule that out. So because it says here, several features distinguish the excessive worry of generalized anxiety disorder from the OCD thoughts or obsessive thoughts. In generalized anxiety disorder, the focus of the worry is about forthcoming problems, so something in the future. And it is the excessiveness of the worry about future events that is abnormal. In OCD, the obsessions are inappropriate ideas that take the form of intrusive or unwanted thoughts. So you're ruling those things out, okay? Post-traumatic stress disorder and adjustment disorders, depressive, bipolar, and psychotic disorders, okay? And then the last down there is comorbidity. So individuals whose presentation meets criteria for GAD are likely to have met or currently meet criteria for other anxiety and unipolar depressive disorders. The negative affectivity or emotional liability that underpins this pattern of comorbidity is associated with temperamental um, antecedents and genetic and environmental risk. So really what it's saying, could you have two different things that are working together, right? So, and then in your treatment plan, you're going to treat the anxiety, and then you're going to treat whatever the other disorder is as well. That was a lot of information, but each one of them has that in it, okay? That you will be reading through to get the best diagnosis. Okay. All right. It is 10:30. We're at the end of the first one. Let's take, how many minutes y'all need?
Maybe 10?
10 minutes. Okay, so went through the first part. So now we're going to get into the mental health interview. So how do we ask all of the right questions to get to a diagnosis, right? Or really is just even to help them. Okay, so and I know this class is diagnosis, but it really is how do we help them the best, right? Okay. So we talked about the DSM. One thing I want to point out here is there's this company called diagnostictabs.com. So if you look at this DSM here, it's got these tabs on it, and those tabs you're able to put that. I don't have my other DSM available, but the tabs, kind of stick out, and it's like you can just read on the tab and go straight to the diagnosis, right? So you don't have to just keep fumbling through the DSM all the time. So it's got those tabs on there, and it takes you directly to um, the diagnosis that you're kind of want to read about and think about. So it's pretty cool. So I wanted to just kind of include that on there. Okay. So specifiers, we talked about specifiers a little bit earlier. So those are extensions to a diagnosis that further clarify the core severity or special features of a disorder or an illness. Let's see what this. Specifiers. So we were kind of looking through. There are different diagnostic diagnosis in the DSM that will say, okay, specifying this. And generally, it's the specifier is it little, medium, large, right? Do they have a lot of something? Do they have a little of something, right? So you can specify it. Or you can specify something like if it's anxiety, you can specify it because it's in from medication or something like that. So you can specify why you're diagnosing something. So remember to consider family history in your assessments, of course. And this is kind of just review, right? Choose the simplest disorder first and work your way to the hardest. So start with the simplest, work towards the hardest. Remember to consider the common disorders first, the horses over the zebras. And then remember the populations you work with when diagnosing. So if you're working with people with substance abuse issues, well, there's probably a lot of that causing anxiety and things like that too. So what's the population you're working with? Dysfunctional. So this is kind of some uh, vocabulary as well. So dysfunctional behaviors and feelings are dysfunctional when they interfere with the person's ability to function in daily life. So, or to hold a job and form relationships. So if you're looking through the DSM in most of the criteria, it will say, does it affect their livelihood in some way? Does it affect their family, their job, their schoolwork, and so on, right? So if it is, so then obviously there's something more to it. But that's one of the criteria is because somebody could say, well, I have anxiety, but it's not really affecting me in some way, right? So, okay, do we really have to diagnose them with something and if it's not affecting them so much, but if it's in the criteria. Distress behaviors and feelings that cause distress to the individual or to others around them, him or her are considered abnormal. So if it's a distress to yourself or you're distressing others in your family, right? Because if you look at narcissism, a narcissist will not know they have narcissism, right? So, but everybody around them may know, right? So that'd be one thing, right? Does it distress the family members over the person? Deviant, highly deviant behaviors like chronic lying or stealing lead to judgments of abnormality. Is it dangerous? Okay, behaviors and feelings that are potentially harmful to an individual or the individuals around them are also abnormal. Okay, those are the 4 Ds that make up the mental health professional's definition of behaviors or the feelings of being abnormal. Okay, so the importance of getting the diagnosis correct. We won't go through this one on page 15, but the importance of a correct diagnosis. And let me know if you can hear, can you hear it? Could you hear that? Okay, can you see it? Can you see a video up? Okay. That's the part I hate about Zoom is that you have to go out, get back in. Okay, so you should be able to see it now, and I'll make sure that you can hear it too. Okay. Can you see it now? Okay.
Wait a minute. back in 1887, a journalist named Elizabeth Cochran assumed the alias Nellie Bly and feigned a mental illness to report on the truly awful conditions inside psychiatric hospitals in the U.S., which were known as asylums at the time. She found rotten food, cold showers, prevalent rats, abusive nurses, and patients being tied down in her famous expose, 10 Days in a Madhouse. What she documented had been pretty standard mental health treatment for centuries, but her work led the charge in mental health reform. It's been a long battle. Nearly a century later, in 1975, American psychologist David Rosenhan published a paper called On Being Sane in Insane Places, detailing the experiment that he conducted on psychiatric institutions themselves. The first part of his experiment involved sending pseudo-patients, a group of 8 totally mentally sound associates, including David himself, to knock on institution doors and falsely report that they'd been hearing voices. Once admitted, the fake patients abandoned their fake symptoms and behaved as they normally did, waiting for administrators to recognize them as mentally healthy. Like Cochran, Rosenhan and his team learned that it's easy to get into a mental institution, but it is much, much harder to get out. The participants were kept in the institution for an average of 19 days, one of them for 52 days. They were forced to take psychotropic medication, which they sneakily spit out, and were eventually discharged with a diagnosis of paranoid schizophrenia in remission. Of course, being dubbed in remission isn't exactly the same thing as being labeled sane, and that was just one of Rosenhan's criticisms of the system. It viewed mental illness as an irreversible condition, almost like a personality trait, rather than a curable illness. Part 2 of his experiment came later, when Rosenhan shared his results with a teaching hospital and then told the staff that he'd be sending more pseudo-patients their way in the next few months, and challenged them to detect the imposters. With that in mind, out of 193 new patients, 41 were ferreted out as likely or suspected pseudo-patients. The thing is, Rosenhan never actually sent in any pseudo-patients. In the end, Rosenhan concluded that the way people were being diagnosed with psychiatric issues often revealed less about the patients themselves and more about their situation. Like, saying you've heard voices one time might catch a doctor's attention a lot more than weeks of normal behavior. Naturally, people criticized his methods and his findings, but his experiment raised a lot of important questions, like how do we define, diagnose, and classify mental disorders? At what point does sad become depressed, or quirky become obsessive-compulsive, or energetic become hyperactive? What are the risks and benefits of diagnostic labeling, and how does the field keep evolving? When people think of psychology, they probably most often think about the conditions that it's been designed to understand, diagnose, and treat, namely psychological disorders, from common problems that most of us will experience at some point in our lives to the more serious dysfunctions that require intensive care. They're a big part of what psychology is here for, and over the next several lessons, we're going to be looking at mental illness as well as wellness, how symptoms are diagnosed, and what biological and environmental causes may be at work. But to grasp those ideas, we first have to find out how we came to understand the idea of mental health itself and build a science around studying, discussing, and caring for it. In 2010, the World Health Organization reported that about 450 million people worldwide suffer from some kind of mental or behavioral disorder. No society is immune from them. But when I say psychological disorder, I'm guessing some of you will conjure up all sorts of dramatic images like diabolical criminals from Arkham Asylum or Hollywood stereotypes of various eccentric, scary, or tragic figures. This roll call of one-sided stock images is part of the problem our culture faces, the misconceptions and often destructive stigma associated with psychological disorders. So, what does that term actually mean? Mental health clinicians think of psychological disorders as deviant, distressful, and dysfunctional patterns of thoughts, feelings, or behaviors. And yeah, there are a lot of sensitive and loaded words in there, so let's talk about what we mean. Starting with deviant. Sounds like I'm talking about doing things that are dicey or raunchy, but in this context, it's used to describe thoughts and behavior that are different from most of the rest of your cultural context. Of course, being different is usually wonderful. Geniuses and Olympians and visionaries are all deviants from the norm, so it probably goes without saying that the standards for so-called deviant behavior change a lot across cultures and in different situations. For example, in a combat situation, killing people is probably to be expected, but murder is definitely deviant criminal behavior back home in times of peace. And in some contexts, speaking to spirits or ancestors is a-okay, but in other settings, say a bar in Iowa City at happy hour, it might not be quite acceptable. But to be classified as a disorder, that deviant behavior needs to cause the person or others around them distress, which just means a subjective feeling that something is really wrong. In turn, distress can lead to truly harmful dysfunction when a person's ability to work and live is clearly, often measurably impaired. So that's today's definition, but it took a long time for the Western world to come up with a way of thinking about psychological disorders that was rooted in science and investigative inquiry. It wasn't until around the 18th and 19th centuries that we really started to put forth the notion that mental health issues might be about a sickness in the mind. For example, by the 1800s, doctors finally caught on to the fact that advanced syphilis could manifest in serious neurological problems like dementia and irritability and various mental disorders. So eventually, a lot of so-called mental patients were removed from asylums to full medical hospitals where all of their symptoms could be treated. This aha moment is just one instance of how perspectives on mental health began to shift toward what's called the medical model of psychological disorder. The medical model champions the notion that psychological disorders have physiological causes that can be diagnosed on the basis of symptoms and treated and sometimes even cured. That way of thinking about mental health was an important step forward, at least at first. It took us past the old days of simply locking people up when they didn't seem quite right to others. But even if it was an improvement, the medical model is seen by some in the field as kind of narrow and outdated. Most contemporary psychologists prefer to view mental health more comprehensively through what's called the biopsychological approach. You've heard us say over and over again that everything psychological is simultaneously biological, and that truism is particularly useful here. The biopsychological view takes that holistic perspective, accounting for a whole number of things both clearly physiological and not, in order to understand what's happening to us, what might be going wrong, and how it can be treated. It takes into account psychological influences for sure, like stress and trauma and memories, but also biological factors like genetics and brain chemistry and social cultural influences like all the expectations wrapped up in how a culture defines normal behavior. So by considering the whole host of nature and nurture influences, we can take a broader view of mental health, realizing that some disorders can be cured while others can be coped with, and still others may end up not being disorders at all once our culture accepts them. But another important part of handling disorders with scientific rigor is attempting to standardize and measure them, how we talk about them, how we diagnose them, and how we treat them. So the field has literally come up with a manual that shows you how to do that. But it is not without its flaws. It's called the American Psychiatric Association's Diagnostic and Statistical Manual of Mental Disorders, or DSM-5, because it's currently in its 5th edition. And it is used by practically everybody, clinicians obviously, but also by insurance and drug companies and policymakers and the whole legal system. The first edition came out in 1952, and this newest version was released in 2013. What's particularly interesting about it is that it's designed to be a work in progress. Forever. Each new edition incorporates changes based on the latest research, but also how our understanding of mental health and behavior evolves over time. For example, believe it or not, the first 2 editions actually classified homosexuality as a pathology, basically a disease. The 1973 third edition eliminated that designation, reflecting changing attitudes and a developing understanding of sexual orientation. And just by looking at the changes between the edition used today and the previous version released in the year 2000, you can get a picture not only of how quickly things change, but also how classification can affect diagnosis, for better or worse, and also what the risks are of classifying psychological disorders in the first place. For instance, the new edition reflects our growing understanding of the symptoms of post-traumatic stress disorder, and it changed the name of childhood bipolar disorder to disruptive mood dysregulation disorder because kids were being overdiagnosed and overtreated for bipolar disorder when the condition that they had didn't actually fit that description. And totally new diagnoses are being explored as well, like gambling addiction and what's called internet gaming disorder, showing that new disorders continue to arise with changing times. But the DSM is not perfect. Even though we've come a long way since the Rosenhan experiment, critics still worry about how the DSM might inadvertently promote the over- or misdiagnosis and treatment of certain behaviors. Others echo Rosenhan's concerns that by slapping patients with labels, we're making them vulnerable to judgments and preconceptions that'll affect how others perceive and treat them. In the end, it's just important to keep in mind that definitions are powerful, and things can get tricky pretty fast in the world of mental health. Today, you learned about how we defined psychological disorders and looked at medical and biopsychological perspectives on mental illness. We talked about how professionals use the DSM to diagnose disorders and how it's constantly evolving to incorporate new thinking. Thanks for watching, especially to all of our Subbable subscribers who make Crash Course possible. To find out how you can become a supporter, just go to Subbable.com.
All right. So what were some of your key takeaways from, first of all, that guy makes me tired. There's a lot of information in such a short period of time. He had a lot of energy for sure. So what are some of your key takeaways that yeah, he was pretty much kind of just reinforcing what we just went through, but what are your thoughts?
I see it's a good thing that they have advanced in the DSM and the diagnosis, especially when it comes to mislabeling someone. I
Uh-huh.
was watching an interview with a psychiatrist, Dr. Thomas Hamlin, with a patient who was mislabeled had of having psychiatric a disorder based on her spiritual and religious beliefs.
Okay.
And that was something that happened back then, 1960. It was the interview where she expressed to him that she talks to Jesus and
Mm.
communicate with Jesus. And she was mislabeled as having
Mm.
a psychiatric order,
Mm.
which is something back in those days happened a lot, especially for women, but also in the Black community. Um,
Mm.
and so, women that were dealing with menopause, sometimes were put in institutions, and all kinds of treatment was done. So it's a good thing that they are advancing. And I heard him talk about that because
Yes.
I think years ago there were a lot of people that were mislabeled of having a problem instead of just it being a culture or spiritual, whatever it was, but it
Mm.
wasn't a mental health disorder.
Yeah, very good. That's a great thing. So, as you were talking about that, there's a place here in Missouri, St. Joe, Missouri, that it's kind of like a mental health museum that they've had, and it used to be, I can't remember the name of it, but it used to be a psychiatric ward as well. But it goes through the timeline of what we considered mental health and how to treat it. Because at one point, it even shows like the tools that people would use for electric shock, lobotomies, things like that too. So you can see where we were and where we've come from, and what we thought. So Jennifer, you had your thought. Thanks, Joyce. That was great. Appreciate that. Yeah.
Sorry, my hand was accidentally waving. I was trying to figure out how to work that thing.
That's
Um,
okay.
I had a couple things. Number one, are you recording? You
Yes,
might
I
be in
think.
a. Okay, I just didn't see it up there, so oh, yep, we are. Okay,
Okay, good.
okay. But
Thank you for that.
I
Keeping me honest.
no, and then I was just going to say what Joyce was saying about just that's what stood out to me is how it's ever changing, like the
Yes.
DSM, and even just with using the DSM as it's like always in process. It's always being revised, and but then at the same time, I always think about how our culture has changed away from biblical principles too. So um, which will affect the way
Yes.
certain things are viewed too. So that
Yeah.
I don't know. I think that'd be kind of hard to discern through.
Yeah. Yeah. And that's one thing about this class too is not to get away from biblical principles and everything too, but really the focus is on the DSM and things like that and what's in it and how you can use, but then how do we spiritually um, involve ourselves with the treatment, and so that's where that's the beauty of what you guys are learning too, is how to do that. Where, if you completely go secular, you're dismissing so much that God has for people, you know. So anyway, anybody else have thoughts?
I agree with Jennifer and Joyce. Like, I
Yeah,
like how it's always changing. Uh,
yeah,
but like what Joyce or Jennifer said, like getting away from the biblical principles. But I feel like having discernment whenever we are talking with these people and using the DSM and in these categories, if it changes in the future, like using discernment and consulting with God for his wisdom and
yes,
correctly trying to get the person to the end goal of being like mentally stable in whatever they are going through.
Mhm. Yeah, and we talk about being, in the image of, we're created in the image of God. And so that us as counselors, that's where we are really helping them to get back to that, right? So when sin enters into the world, it diminished the image, right? And so that's us as counselors is trying to help them. What is obstructing? What's keeping them from um, being in the image of God, and how do we help them get back to that? So, Joyce?
Yeah, and with the internet and social media days, I see a lot of self-diagnosis out
Hmm.
there. I can't count how many people who've diagnosed themselves as adults as ADHD, so
Oh, I
bipolar,
know.
and so many things that, it almost breaks my heart because, I don't know what their end game is. I don't know if it's for attention or if they're really trying to find out what's going on with them.
Hmm.
But for me, you should go seek professional counseling before you tell the whole world, that you have this disorder because some of those,
Yes,
those disorders are very serious and they can impact your
absolutely.
life. So, but I see it's happening so often and it really is doing a disservice for them more so than the profession. So, yeah.
Absolutely. Thanks for bringing that up. And the other part is just think about somebody who self-diagnoses as ADHD. They go somewhere and they say, yes, you have ADHD. If they don't, and then they give them this medication that's more or less speed, and they're taking this medication and it's not helping them one bit, or it's even hurting them in some way. Anyway, I can get up on a soapbox for a long time on all that stuff, medication and things like that. So anyway, and maybe we will talk about a little bit about later of like wholeness care. You know what I mean? I totally believe in supplements and things like that, and exercise and all those things. What else can we do that will help instead of, I mean, I would want medication to be the last unless it's something that they really need. Um, anyway, okay, let me bring this back up. Anybody else have any thoughts? Get back to the okay. So this will be kind of what we'll be going through here is the roadmap to the diagnosis, right? Gather the complete information, identify syndromes, construct a differential diagnosis, decision tree on how for treatment. Maybe we identify other diagnosis or comorbidity with what we're working with the client, then writing up a treatment plan or formulation of a treatment plan to what are our steps that we are going to be taking to help this individual, and then reevaluate the diagnosis. Is it the correct one? Is there anything else that needs to go with it? Specifiers and so on. Okay. So the mental health interview is your intake that you're doing at the very beginning of when somebody comes in, okay? So it is a comprehensive mental health interview, and it's the cornerstone of obtaining all the information you need to make an accurate diagnosis and provide the treatment available for it. I don't have any of these books with me. But what's really cool is if you use your DSM and then you come up with a diagnosis of something, then there's a lot of books out there that will help you with a treatment plan for it. Say, like you're saying, if you diagnose with OCD, here's a treatment plan that you can use, um, or just at least get thoughts from. And there's a ton of them out there. They're really good. And they'll state like they're clinical, right? So those are really good tools to use. So the mental health interview is also designed to collect sufficient information to make that diagnosis, determine a treatment plan, and develop that treatment plan and implement that treatment plan, right? The initial interview is required by virtually all third-party payers and accrediting agencies. Why do you think that is? Why do you think it's required? This mental health diagnosis, or MSE is what they call it, mental status examination. Why do you think it's required?
Well, I mean, just I don't know if this is what you're talking about, but that's how we're going to learn. We're going to learn by observing people, noticing what we see, and so that's I mean that's a huge part of the assessment.
Yeah. Yeah, good. So when you're doing these mental status examinations, it's a list of questions that you're going to be going through. And you don't skip over them, you do them all. So these third-party payers are like going, if you've done all that, you've acquired all the information you need to make an accurate diagnosis of some sort, right? So that's why they're required. So and it would be part of the notes. So if you have to turn over notes or anything like that um, for a payer, they want to know that you've done that intake like that. Okay. So, introduction to interviewing, right? So, three skills are are the most important part about it, right? So, the first skill is your relationship building, that therapeutic alliance that you're building. So that involves trust, authenticity, genuineness on both parts, right? So it's that relationship building and the trust that you've built to get an accurate account of information that they're given to you, right? Sometimes if you don't have that trust built, they may be withholding from you and not give all of the details, maybe out of shame, guilt, whatever. So if we don't have that therapeutic alliance, and that's the hardest part is if you are working and you have to, and they're have insurance and they're using insurance, I mean, the hardest part is the insurance is wanting you to do this really quickly, but building a therapeutic alliance sometimes takes a long time for somebody to develop trust in you. So see, you may be up against something if if you are working with insurance and so on. Diagnostic skills, so skills and knowledge of psychopathology. What's the treatment? How did we get to where we are genetically, whatever it is, right? So being able to understand and have that knowledge and wisdom. Then the documentation skills are important. Skills and knowledge of third-party requirements and report writing. So what this is also saying is your notes are so important, and because if you're seeing 30, 40 people a week, and you're not taking good, and keeping good notes, you might not remember from week to week, the importance of, what of working with this individual. So establishing good habits to create good notes is so, so vital important. Okay. So before the interviewing starts, establish that good rapport, that therapeutic alliance that you that you need to establish with them that enhances that accuracy of the information that they're providing to you. Okay. So the distribution of time, 50% to the chief complaint, 30% pursuit of your specific diagnosis, 50% of it medical history. This is your interviewing. 25% to your personal and social history, 10% to the MSE, the mental status examination, and 5% discussion of diagnosis and treatment with the patient. And that's, should be done after you've done all of those things and you've come up with a diagnosis. Okay, You are including them. You're not just creating a treatment plan on your own. You're including them in this treatment. Why do we want to do that? We want to do that so that they take ownership, responsibility, and they have buy-in that the care that they're being provided is a partnership and not just somebody saying, you got to do these things. Well, because you wanted them to understand that it's a partnership, so they'll do the work. Okay. Okay. So we'll go through these. The biopsychosocial assessment is that interview. Okay. The biopsychosocial assessment refers to a series of questions at the beginning of treatment of an individual that obtains information about the major physical is the biological, right? Psychological is the mental, and the social issues of that individual is, what's their environment like? What's their genetics like? And so on, okay? This approach is called holistic because it suggests that separate issues are often related. Is there physical? Is there psychological? Is there social? Right? All of these are related. The course of a physical illness could influence social interaction or psychological function, or a social and familial background might have an impact on biological or psychosocial. So each one has an effect on the other. Okay. So by asking these questions, that establishes the most important elements of each of these spheres. So what's going on within each of the biopsychosocial so that we can create the treatment plan that covers holistic care. Okay, family history, medical history. This is what it looks like, right? And so there's questions under each. So education and employment history, alcohol and drug use, legal history. Why do you think we want to know their legal history? What would be involved in knowing their legal history, you think?
Could it be patterns?
Yeah, it could be patterns. Yeah, absolutely. Yeah. Maddie, you were going to say?
Well, for me, especially working with kids, it's I want to know their legal history, so I want to know if I'm going to be dragged into some kind of debate or whatever, not debate, custody situation, right? I want to know
Hmm.
if they have an ongoing that, or I also want to know if they have ongoing like DSF case as well going on in the family because it gives a lot of context about what's going on in the family, but then it also gives me information about whether or not this is the kind of case that is suitable for me to take on or if I need to refer it to someone else that may be more suited to
Yeah,
do maybe forensic reporting or whatever it is, you know what I mean? So,
absolutely. Yeah. Great. Both of you great answers. That's awesome. Yeah. So another part of the legal could be this. If you okay, say somebody is leaning and you're leaning towards bipolar. Okay. So sometimes when people get in a manic situation, that bipolar, be part of bipolar, they there's a lot of legal things that they break laws sometimes, like maybe maybe there's DUIs or there's they get in trouble of some way, because they've oh, I can't remember the word, but anyway, so it could lend itself when they become manic, they have law issues or something. So then, okay, what was happening during this time when you were arrested for this, this, and this, right? So then you could uncover some things in that. So there's a lot of um, things that you can get from their legal history. So I like both of you guys' answers there. So prior mental health treatment, Absolutely, we want to know those things. What was their prior mental health treatment? What medication they're on? That's going to tell a lot. Because if you're doing this interview with them and they say, well, I'm on these different types of medication, you can look at it and go, oh, well, they've been probably diagnosed with X because this is the medication that they would use for these things, right? So the prior medication is always good. And maybe they're not taking that medication anymore. So maybe they should be, or maybe they've overcome something or whatever it is. What was their prior medication? Also, going back up to medical history, you know, um, was there something in their medical past, like a physical thing that had happened or some kind of sickness that they'd had that maybe they had been taking some form of medication that would lend itself to this mental health issue. So much going on and that you need to find out. Okay. Okay, so you create the atmosphere of this, right? So too often in this day and age, people are in a hurry to get to the point and rush to a solution. When I'm doing supervision so much, people are always wanting to fix others. I'm like, take your time, slow down. There's a lot of things that you got to go through, to understand what is happening. So take your time, slow down. Um, if you're going through the change process, there's pre-contemplation, contemplation, and planning and action, right? We always want to go from the pre-contemplation to the action stage without, and skipping these two so that we can get to the fixing part. There's a lot of stuff that we've got to do to get there. So most of it is building that therapeutic alliance and building that trust. So the intake process helps that therapist slow down that client, right? Assist them, assist both the counselor and the client with obtaining a clear focus on the past and the present issues so that we can move forward and address the future. It informs the counselor as to the direction to take during this whole counseling process, right? So the flow of the intake should look like this. Make sure that they understand confidentiality, mandated reporting. So if they come to you and they say something like, I'm going to hurt myself, I'm going to hurt somebody else, um, I know of elderly abuse or child abuse or something like that, that is something that we have to report. And they need to know that we are mandated reporters and that it will be reported if they say certain things, if they're going to be harm to themselves or so on. We want to make them feel comfortable during this intake, go through the intake and allow questions. We want to allow questions so that they feel like they're really a part of this because they are. They are a huge part of this. And once you come up with a plan, we want them to take ownership of that plan. Importance of being honest with you and themselves. And then the importance of following the plan and the process. And so if you've taken the class helping skills, there are several types of skills to do. We won't, get into this much, but the attending behaviors are what you're going to use during this time, during this intake process that helps them to feel comfortable. So using good eye contact, your body posture, sitting forward. There's this thing called solar, sitting square, upright, and so on. So your body posture, your tone of voice that you use, is it soothing? Is it, will you get serious at times? Will your tone of voice get serious when you need it to? Your verbal tracking and so on. So the solar is sit squarely, open posture, lean towards them with good eye contact. And the R is relax during this time. So that's the part, relax and slow down and get to the meat. So other helping skills you'll be using clarifications, paraphrasing, summarizing back to them, reflecting of feelings. My favorite one that I harp on a lot is silence, right? Man, if you ask a question, be quiet, right? Let them answer because a lot of times they'll be processing and we don't want to interrupt that. And we have to figure out why we need to break that silence. Is it that I'm trying to rescue them for some reason, right? So if you ask a question or something, let's, you know, honor that silence. Okay, so here's take a look at an intake example. Tell me if you can hear this or not when it comes up. Hang on one second. Can you see it, first of all? Can you see a video? Okay. Okay. You should be able to hear it and see it in a second.
Hi Sam, how you doing today?
All right.
You doing all right?
Yeah.
I see that this is the first time you've come in. You filled out some of the other paperwork.
Yeah.
Yeah.
20 of them. Mm-hmm.
A lot of pages.
Yeah.
How'd that go?
It went. I mean, I've seen that stuff before, but it wasn't too bad.
Nothing surprising in there.
No, pretty standard.
Pretty standard. Nothing distressing.
Not yet.
Not yet? Okay. I'm going to ask you a series of questions as part of a process called intake.
Mm-hmm.
Right, so this document that I'll be making notes on will go in your chart, and it'll help guide your care for the time that you're with me.
Okay.
All right. So these questions are going to be more detailed and more emotionally oriented than a lot of those questions that you were answering on the forms you filled out before.
Okay.
And that was more like factual information that we need for insurance or record keeping. And this is more about you and what you've been going through.
Okay.
You comfortable with that?
Yeah, it's okay.
It's okay. All right. If at any time you don't like one of the questions or you don't want to answer one of the questions, just let me know, and we'll just skip over that.
Okay, fair enough.
All right. So what brings you in today?
I brought myself in. Things have just not been fantastic, so I figured I might as well get some help before it got worse.
All right. Things haven't been fantastic,
Yeah.
and you're worried they're going to get worse.
Seems like it, yeah.
Yeah. What would you say that your main problem is that motivates you to come in?
Probably my anxiety.
Mm-hmm.
I'm just nervous about a lot of things a lot of the time. And it's kind of trickling into every area of my life now.
Yeah. So anxiety?
Mm-hmm.
And you said it was like a nervousness that's...
Yeah, just like nervousness about going places, or nervousness about doing things, or school, or work, or, graduating college, just kind of that whole stage. And it's been like that for a while.
How long?
I can remember as far back as like 13 or 14 maybe.
Yeah. And how old are you now?
23.
So this is around 10 years you've been
Yeah,
coping with this.
off and on, yeah.
Yeah. Off and on?
Yeah.
So there's times when you're not anxious?
Not as bad. I mean, I'm still anxious, but not as extreme, or I don't deal with it in the same way.
If you were to rate your anxiety on a scale of 1 to 10, with 1 being really no anxiety and 10 being the worst it's been in the last 10 years, how much anxiety do you have right now?
Like a 6.
When was the last time you were 10?
Last weekend.
When was the last time you were 1?
I'm not really sure.
No? Approximately?
maybe like a couple months ago when I was just hanging out with my friends. We went out and we were partying a little bit, and it was nice. I wasn't super anxious.
Right. About a couple months ago?
Yeah.
Okay. So the anxiety is one problem. Any other problems?
I don't think it's a huge problem, but I have been drinking a lot. That it helps with the anxiety, but it makes going out and, I'm more relaxed that way. But I can be kind of a compulsive person, so once I start, I keep going. So it's not all the time. It's just happening, when I'm going out, but I end up drinking too much. And
So sometimes when you go out,
yeah.
you drink more than you want to.
Yeah.
What happens then?
I make bad decisions, or I get sick, or the next morning I'm showing up hungover going to class, if I make class. And, it's fun for the time being, but it's not fun afterwards.
So the consequences of drinking in the longer run,
Yeah.
you're not too fond of those, but in the short run,
Yeah, it helps in the moment.
okay. So you want the anxiety to be lessened. Do you want the drinking to be lessened?
Probably. Yeah, I mean, I'd like to still have fun. I'm in college, but I would like to not be, blacking out, or being able to stop would be nice.
Is that what happens now? You black out?
Occasionally, not every time, but sometimes.
Sometimes?
Yeah.
Do you remember the last time you blacked out?
Maybe a month ago?
A month ago?
Yeah. It's not all the time, so.
At what age did you start drinking?
14?
At 14?
Yeah.
All right. Any other problems? You have anxiety, and you have drinking alcohol.
Mm-hmm.
Any other problems?
I don't think so.
Right. So those are the two main things that are
Yeah.
bothering. Okay.
Yeah.
All right. So I want to ask you some questions about your history.
Okay.
All right. And I'm going to try to divide this up into different areas and just kind of move from one area to the next. There'll be some overlap.
Okay.
So if I ask you the same question more than once, it's just kind of part of that overlap that occurs. All right. First, I'd like to cover your family history. So can you tell me about your immediate family?
I have one sister, mom and a dad. Pretty typical. My sister is really successful. She's a doctor. Both my parents are really successful too. So, basic family.
All right. What type of relationship do you have with your sister?
Kind of like a Merry Christmas, Happy Easter type of relationship. Or more like acquaintances than we are siblings.
Would you describe it as distant?
Yeah, I'd say so. I mean, we're nice. We're not but we're not going to be involved in each other's lives, really.
Do you know what caused the relationship to end up that way?
I don't know. She was always kind of the ideal child. She went and did everything that she was supposed to do, and it was easy for her. So constantly being compared to that doesn't really foster a great relationship.
Who compared you to your sister?
My dad, usually.
Yeah.
Sometimes my mom. Depends on the day.
Was this a frequent occurrence, the comparison?
Yeah, for sure.
Do you feel like it had an impact on you?
Probably. It wasn't like I wasn't trying, but not everything can be as easy as it is for some people. So, a little acknowledgement might be nice.
All right. So let's move out a little further. So you talked about your mother, your father, your sister. Any other siblings?
No.
No. How about grandparents?
They're around. Typical grandparents, not super involved, but they're there sometimes.
Good relationship?
Yeah, I mean, grandparents show up and it's always like, hi, how's it going? And, you see them at the next holiday type of thing.
All right. So there's not one grandparent you're particularly close to?
I do have one grandfather I talk to on on a more personal level than I would my other ones, but that's gotten more distant in the past couple of years.
How about aunts, uncles, cousins?
I have a couple of cousins that I would hang out with, or I'll see out when I'm hanging out with my friends or whatever. So we'll hang out if we run into each other. Aunts and uncles I do have. They're not super involved either, but everybody's cordial. You know?
Everybody's cordial.
Yeah, nice when they see you type of thing.
All right. So when's the last time you spoke, say for example, with one of your cousins?
I think I ran into one of them like 2 weeks ago when we were just out.
A couple weeks ago?
Yeah.
All right. Do any of the relatives that you mentioned, are any of them aware of your anxiety and or your drinking?
My parents are.
Yeah. Nobody else?
My sister knows about the anxiety part of it. And I'm pretty sure she knows about the drinking, but she doesn't bring it up. But if my parents know, I'm sure she knows.
So you believe that they told her?
I'm sure.
Yeah. But she's not mentioned that to you directly?
No, we don't have those types of conversations. It's more like, oh, she messed up again, and it's just sort of like this like funny thing, and then they move on. So.
All right. So I see this bothers you.
Yeah. It's annoying.
Annoying?
Yeah.
Some of these topics that we're going to touch on in this intake, we can talk about in greater detail later on.
Okay.
All right. So, and maybe your relationship with your mother and father and your sister would be topics we would touch on later on. Maybe not, but I want to let you know that we can come back to anything and review it.
Okay.
All right. So I want to move kind of out of family history a bit and move to social relationships.
Okay.
All right. Again, it's kind of similar, a little bit overlap here. Can you tell me about any romantic interests, friends, anything like that?
Yeah. I have a guy I've been seeing for like 6 months, so it's pretty serious for college.
Okay.
And some of my college friends I'm really close with, so they're there with me for a lot.
About how many?
There's 3 girls that I'm super close with. And then, you know, college, there's a lot of people I'm acquaintances with, or I'll see or talk to in class or whatever. But those 3 girls are kind of the ones I would go to if I needed something.
All right. And then you have some other friends that you're not as close to?
Yeah, I mean, we're nice and we have fun, and, you know, I'm sure if something happened, they would bail me out, but they're not like people I'm going to talk to about my problems or anything like that.
Do they know about your problems?
I don't know. I guess you could know, like, when I show up to class hungover, but I'm sure I'm not the only one doing that, so.
And how about you said the guy you were seeing for 6 months, does he know about the problems?
Somewhat, yeah. He knows about, definitely knows about the anxiety. And he's with me a lot when I go out, so if something does happen, he's usually helping me out or making sure I get home or whatever.
So he's supportive?
Yeah, really supportive.
All right. So some of the questions I'm going to ask you, this gives me a good opportunity to talk about this. I probably could guess the answer to, but I still want to ask, not be presumptuous.
Okay.
Do you have any children?
No.
Okay, how about nieces or nephews?
No.
Any other social relationships that I've missed here that are important to you?
I don't think so. Those are the main ones right now.
Yeah. All right. She said you were 23. I want to ask you some questions about your medical history.
Okay.
All right. Have you had any surgeries in your lifetime?
Got my appendix removed.
Appendix removed?
Yeah.
Any other serious medical conditions?
No, I've had my wisdom teeth taken out. That
Wisdom
counts.
teeth extract?
Yeah.
Are you on any medications for physical problems?
No.
All right. How about your activity level? Do you stay fairly active?
Yeah, I try to.
Yeah.
I go to the gym like twice a week or whatever, and I go to yoga sometimes. So yeah, I try to get out.
All right. So you consider yourself an active person?
Yeah, I try to be in between, classes and everything else. But when I do have the time, I enjoy going out and doing things.
Okay. Would you generally say you're in good health then?
Yeah, physically, yeah.
Physically?
Yeah.
All right. No other illnesses, surgeries, procedures of note?
No.
All right. So I want to shift gears a little bit again, and now talk about psychiatric history.
Okay.
All right. And what I'm getting at here is kind of a history of any diagnoses, medications, other times have been treated by a counselor or somebody like a counselor. Let's start with medications. You know, any medications?
No, not really.
Mental health, no. How about history of diagnoses? You ever been diagnosed with a mental health condition?
Yeah, I was. I was seeing a therapist before a couple of years ago.
Mm-hmm.
I saw him a couple of times. I think he said I had some sort of anxiety disorder or something.
Do you remember specifically what he said?
Something more general. So, it wasn't about any particular thing.
Mm-hmm.
So I saw him for a little while, but I just really wasn't on board with the whole therapy thing at that point. I didn't think it was going to help, so...
And how old were you yourself?
15 or 16, yeah.
All right, so, and that was a counselor?
Yeah.
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 All right, so you saw the counselor. The counselor indicated you had some type of anxiety disorder.
Yeah.
Do you feel that was a fair assessment?
I think so.
Yeah.
Yeah.
And how long did you see the counselor?
I think about 5 or 6 times, maybe.
5 or 6 sessions?
Yeah.
And why did you discontinue the treatment?
I don't know, I just didn't really feel like I was really involved in it, and it felt like it was more a waste of my time, and his wasn't ready. I don't know that I was super on board with the whole anxiety thing at that point. I mean, he was nice, there wasn't an issue with him. I wasn't there.
Any mention at that time about the drinking?
I think I brought it up, but I didn't really see it as an issue then.
How about other mental health professionals, like a psychiatrist, a psychologist, a marriage and family therapist?
My parents took me to see a psychiatrist maybe once or twice, but didn't really stick with that either.
You weren't prescribed any medication?
No.
And what do you think happened there that you didn't stick with that?
I think kind of the same thing. I knew that obviously there was something going on, but I don't think I was ready to deal with it. And I kind of felt like I had it under control at that point.
Can you tell me about when you saw the psychiatrist in relation to when you saw the counselor?
It was all within that same time period. I think I saw the counselor first, and then maybe the psychiatrist a week or 2 later, and then followed up with the counselor. But I just wasn't really present during any of it.
Mm-hmm. Do you feel you're in a different state of mind now?
Yeah, I think so.
Tell me about that.
I realize now that I'm not handling it like I thought I was, and it's affecting other areas of my life. And, I'm in my senior year of college, I need to get my life together, and I'm not really doing that so well. So, I think it's time to figure something out.
All right, so you feel like you're ready to commit to treatment a little more uh, vigorously
Yeah,
at this point. Okay.
yeah, I want the help now.
And back then,
No.
no. Okay. And no other treatment providers.
Nope, just those.
Okay, just those two.
Okay. All right. What do you think he did well in this video? He's got a lot of videos up there. What did he do well with this person?
I think his question was very good. And it helped to open her up a little bit because I could see that she really wasn't opened up because she was doing this.
Yeah.
Um, Although I fold my arms a lot too, but it doesn't mean the same. I'm just not don't know what to do with my hands. So I think that his line of questioning was really good and helpful,
Mhm.
to kind of understand her, and for her to understand herself as well and what's going on. So I think that that was good.
Yeah. Yeah, good job. What else did he do well? I agree with his questions. I mean, and they flowed well. What else did he do well?
There was one question that I really liked that he had asked, and I liked the way he had asked it. I actually wrote it down because I was like, I think I'm gonna do that.
Okay.
He had them rate the symptoms, how to rate the symptoms from 1 to
Mm.
10, which that's pretty standard. But then he was like, when was the last time you were 10? And when was the last time you were a 1?
Yeah.
And what are you right now? And I thought that, the first part of like rate your symptoms 1 to 10, what are you right now? That's pretty normal. I've done that plenty of times. But I really liked the when was the last time you were a 10? What was that like? When was the last time you were a 1? What was that like? So you can get a better, like, almost like working Likert scale for that particular individual to know, like, for them, what is a 10? For them, what is a 1?
Yeah. And how long
Um,
ago?
and
Yeah.
how long ago was that? Yeah, was that like 2 weeks ago and that's why you're in here? Or was that like months and months ago and you've already done stuff to maybe
Yeah.
improve it, but you don't really realize or whatever, right? So,
I love that. Yeah. That was my probably my favorite part too. I like that. He did a really good job with that. Especially and she goes, "When were you at a 10?" And she goes, "Last week or something." What are you at now? Yeah. That was very good. Anything else that you noticed? All right. What could he have done better or differently? What could he have done better or differently? Or what would you have done differently?
I feel like I would have just kind of um try to ease her mind off of like the what's wrong with you and just kind of ask her about like how was like her day or what are some of her interests or kind of like that where it doesn't
Mhm.
feel so cold. Um
Yeah.
that was what stood out most to me. It was just like, okay, we're going to look at this paper and we're only going to talk about this paper today. But I do get the point of it, and I really do like that because he was getting like straight to the point. But I also would kind of figure out how to make it feel a little bit more warm.
Yes. Yeah. So that therapeutic alliance, right? Yeah. That's good.
well, and I think the severity of what the person's coming in with present like what their presenting problem is also kind of should determine a little better like how cold you end up being to some extent, right? Because if we're really acute, then it's like you can even preface with, "Hey guys, I'm really sorry. I don't want to be cold. It's not my normal style, but I really want to help you get this problem figured out. So I'm going to ask you a lot of really direct questions, super, one right after the fire. I'm all it's kind of feel like a fire hydrant for a little bit. Promise it's not going to stay like that the whole time we're counseling or whatever. But like she's coming in with like some general anxiety stuff, whatever, right? Like there's enough time, like Marietta said, to like, hey, how's it going? Nice to meet you. Let's get to know
Yes.
each other a little bit more before I just like. And then the other thing I thought he could do differently too was and I know this is technically the correct language, but he's like, what other problems do you have? And I'm like,
Yeah.
I, I don't know. I'm here to help. I'm here to have you help me figure that out. Like, you keep asking me about my problems. Am I just a thing to solve? Which for someone with anxiety probably
Oh, yeah. Yeah.
wasn't very comforting.
Yeah.
Like, I don't
Well,
know.
I guess what he could be fishing for is like, are you a self-diagnoser and what other
That's
things?
fair. That's fair. Yeah. What other problems do you see in your life? Right. That is an
Yeah.
appropriate question. I'm not necessarily saying that
No, no,
that,
no,
but
no.
the way he asked it was just like,
Yes.
what other problems do you have?
Yeah.
Like, I'm not like smiling at you. I'm not
Yeah.
changing my tone inflection,
Yeah.
staring at you like I'm bored and I don't want to be here with you.
Yeah, I think that's for me is like the biggest thing, especially with this guy. He's like so monotone and he's so seems like he's a psychiatrist, psychologist type person, and the counseling is just not part of, who he is. He does a lot of videos, and I think, these videos that he's done a lot of those in the past, and now he's moving towards more the clickbait type ones. So uh, anyway, yeah, he's different. I mean, he's got a lot of really good info, but. Yeah. Any other things that you would do differently? And obviously, so that was a three-parter, and we just saw the first part of it. So I just wanted to kind of give you a taste of what it looks like to be, going along and the importance of asking all of these questions in it. So, and it takes a long time. So that first one, if you're doing a biopsychosocial assessment with them, it may take more than first session, just depending on all that's involved. Or it may just take 10 minutes and you get to it, just depending on what the whole issue is. All right, let's get to just a little bit more and then we'll kind of take a break here. Back to this. Okay. Okay. So the MSE, what he was doing, the mental status examination, right, is so more things that you're going to be doing as well with these individuals, especially when you're doing your notes. You want to, what is like the clinical observations? So just think about when you see a cop and they pull somebody over, or there's been an accident or something. What do? They go, okay, the weather was this, it was raining, the weather was this, there was no ice, there was, it was temperature was this. So they put all of these details in there so that you can understand what the circumstances were of this car accident or speeding or whatever it was. Okay, so same with clinical observations, right? So clinical observations are what's their appearance? Do they have good grooming, good hygiene? What's their body type? Do they have instances of medical issues and things like that too? What's their activity level? Do they have odd mannerisms, symptomatic movements, mobility? Did they maintain eye contact with you during the whole time? What was their speech like? Was it slurred? Was it on point? What was the rate? So sometimes when they come in, you can, maybe they have a different rate. And so maybe there's anxiety. There's all kinds of things that could be going on, right? Attitudes towards the examiner. Were they being defensive? Were they indifferent, guarded, hostile, and so on? Okay. Stream of consciousness was, were they blocked, slowed, average, rapid, loose, circumstantial, and so on? Thought content. Were they able to give you good content flow with their thoughts? Um, Affect. Were they flat, blunted, congruent? Were they tearful, sad, so on? What was their mood like, right? So we want to so this is in every session too. You can put this stuff down if you want to measure what happens in every session, right? So if that's if you have somebody that comes in and that's not the most important part, you wouldn't have to go as extensive. But if you have somebody with a mood disorder or whatever, you want to be able to put all this in here. Okay. So here's what else you can look for. What's their body language telling you? See, Joyce, you picked it right up that she had her arms crossed, her legs crossed. Well, what's it tell us? She's closed off, she's defensive, she's all of these things. Could be shame, could be guilt, could be a lot of things in there that we want to investigate. How open were they to discussing their issues? She seemed fairly open, but she seemed a little guarded too. Is it because of him? Is it because of shame? Is it because, so it's our duty to kind of figure all that out. Did they keep good eye contact? How much thought are they putting into the words that they're choosing? Are they processors? How attached they become to you, right? Is important. Maybe they have attachment issues, right? So, we want to look for a lot of things. Psychological capacities to view self and others in complex, stable, and accurate ways. What's their identity? How did they view themselves? To maintain object relations, to maintain intimate, stable, satisfying relationships. Are they good at that? Can't remember what she said, but I know they talked about her family a little bit during this. So, to experience and self and perceive others the full range of age expected. What's their affect like? Impulse control, affect regulation, emotional regulation. So we want to look for all of these things. Okay. That is what we have for the mental status examination or their intake. Stop there. So let's take a break here. It's 12:05 now. Is an hour okay? 1:05? Okay, we'll come back at 1:05. All right. Thank you guys.